Hello, thanks for being with us here today. My name is Juan Luis Giraldo. I'm an OBGYN specialist in reproductive medicine. And today we're going to talk about infertility workup in the infertile couple. I hope that these few minutes are useful to have good conclusions about how to do this diagnostic workup in these infertile couples in a practical manner. So we're going to go over how to do a diagnosis of infertility, what are the causes of infertility, the diagnostic workup, talking specifically about ovulatory function, tubal function, uterine cavity, semen analysis, and at the end, we're going to talk a little bit about endometriosis and about unexplained infertility. So first thing we need to know is how to do the diagnosis of infertility. So infertility is conceived as the failure to achieve a clinical pregnancy after 12 months of more of regular unprotected sexual intercourse without achieving a pregnancy. So there's two kinds of infertility. First is primary infertility. That's about 75% of the couples with infertility, and are those couples that never had a pregnancy before. And the second kind of infertility is secondary infertility. It's about 25% of all the couples with infertility that are those couples that have had a pregnancy before, either that have finished in a live born or that have been a lost pregnancy because of a miscarriage or an ectopic pregnancy, for example. Those couples with secondary infertility are couples that have a better prognosis in terms of the results of the fertility treatments in search of a pregnancy. But to be able to assess these couples with infertility, it's important to know what is the time to pregnancy in us humans as a species. So for that purpose, this slide shows us 100 couples that stop any birth control methods. Let's talk about birth control pills, preservatives, condoms, intrauterine devices, and start looking for a pregnancy. During their first year, during each one of those menstrual periods or those months of that first year, their possibility of a pregnancy is about 15 to 20% per month, per menstrual period. So by the end of that year, of those 100 couples, approximately 85 of them had achieved, will be able to achieve a pregnancy. At that point, if they haven't gotten pregnant by the end of that year, we are going to do a diagnosis of infertility, because in those 15 couples that didn't get pregnant, the possibility of getting pregnant during their second year of looking for that pregnancy for each month of that second year is going to be not anymore 15 to 20%, it's going to be 3 to 5%. So there's a big drop down in that possibility of getting pregnant during that second year. And that's why we do that diagnosis of infertility and need to do a diagnostic workup to find out what is the cause of that difficulty to getting pregnant. In this slide, we also see the possibility of pregnancy through time. So you see that during the first 12 months, approximately 85% of the couples are going to be pregnant. And during the next year, from month 12 to 24, approximately 50% of those 15% of the couples that didn't get pregnant during the first year are going to get pregnant. So you're going to see that in the first month of having sexual unprotected sex with regular intercourse, 25% of the couples are going to get pregnant. During the first 3 months, 57% are going to get pregnant. In the first 6 months, 72%. In the first 12 months, 85%, like we said before. And in the first 24 months, 93% of the couples are going to have a spontaneous pregnancy. So this concept is really important, because when we say or when we give a name to that diagnosis of infertility, it kind of implies that that couple is not able to get pregnant, and that's false. Most couples really have a possibility of getting pregnant spontaneously but diminished compared to those couples that do not have an infertility diagnosis. So the best way to call this disease, this concept, is subfertility instead of infertility, because they still have a possibility of a spontaneous pregnancy, although it's diminished. This concept is important: aging and fertility, and are they forever enemies or not? So we're going to go over that. So in this slide, you see how the fertility potential behaves in women. There's new evidence that shows that the aneuploidies in the eggs, in the oocytes of really young women between 12 and 18 years old, have an increased aneuploidy rate comparable to those aneuploidy rates found in women with advanced reproductive age. So that means that the fertility potential is not maximal in really young women. It increases from 12, 13 years old up to 20 to 25 years old when women achieve their highest fertility potential. At this point, that fertility potential is maintained up to 30 years old approximately, and it starts to diminish after 30 years old, not remarkably until 35, but really fast after 35, and even more after 37 or 38 years old. So that's how fertility potential behaves in women. Why? Because in men, you know that we produce new sperm cells every day. So spermatogenesis is a continuous process during all the life of that man. So all men in this audience has sperm cells when which the oldest sperm cell is 80 to 85 days old. That's the time of maturation of the sperm cell, between the time it's produced until the time it's mature and can be ejaculated. But women do not behave that way. Women can only produce eggs and oocytes in their ovaries up to the 21st week of fetal life. Oogenesis or mitosis in oogonias can only works up to that 21st week of fetal life. After that 21st week, we see only two cellular processes in the ovaries of those women. We see follicular atresia and eggs oocytes that go into meiosis and stop their development in prophase of that first meiotic division. That's why up in the 21st week of fetal life, women have approximately 5 to 6 million of oocytes in their ovaries. But since many of them enter into follicular atresia, when that baby, female baby, is born, the number of oocytes in her eggs, in her ovaries, is not anymore 5 to 6 million. It's approximately 1 to 2 million. And when that girl reaches puberty, the number is diminished to 300 to 400,000 oocytes or primordial follicles in her ovaries. That's because of that process of follicular atresia. And that occurs before that woman ovulates for the first time. After that, of those follicles or eggs that are kind of cryo, like sleeping in the prophase of the first meiotic division, 500 to 1,000 of those follicles activate or are recruited for every menstrual cycle. And their maturation process takes about between 3 to 5 months, and they kind of run a race between them, and the most competent follicle or egg reaches maturity and is ovulated. But the other 500 to 1,000 eggs go into atresia and cannot be replaced by the ovaries. That's why the number of follicles and eggs in those ovaries diminish during the increase of age in those women. And not only the number, but also the quality. And that's why fertility potential diminishes with age. So this is the possibility of having infertility or of childlessness according to the age group of those women. This was published a long time ago in women that got married and were exposed to pregnancy in different age groups. So when women are between 20 to 24 years old, when they start to expose to pregnancy, their possibility of having infertility is 5.7%. When they start looking for a pregnancy between 25 and 29 years old, it's 9.3%. When they're 30 to 34 years old, the possibility of infertility is around 15%. When they're 35 to 39 years old, it's approximately 30%. And when women are between 40 and 44 years old, the infertility possibility or rate is over 60%. So there's definitely an effect on fertility prognosis in women with age. And there's a persistent misperception that assisted reproductive technology can reverse that aged biological clock. And this is not true, definitely not true. And you can see that in the rates of life born per embryo transfer reported preliminarily by SART in 2019. In patients under 35 years old that go to IVF and have their first embryo transfer, their life rate is around 35.8%. But in women older than 42 years old, their live birth rate for embryo transfer in their first embryo transfer is going to be around 2.9%. So definitely IVF does not reverse that age biological clock and diminish ovarian reserve in women. So when to intervene, when to treat this patient, study this patient, and start the infertility workup. So every patient or every couple that's going to look for a pregnancy should have a preconceptional evaluation. If the preconceptional evaluation is okay, and that couple starts looking for a pregnancy, and that woman has less than 35 years old and has had unprotected sexual intercourse for 1 year or more, they should be analyzed by a reproductive medicine specialist and have a diagnostic workup for infertility. That period of time is less. It's 6 months if that woman is 35 years or older. If that woman is 40 years or older, that couple should be managed for potential infertility from the beginning when they're going to start looking for the pregnancy, because of the age, the possibility of infertility is going to be over 60%. But besides, if during that preconceptional evaluation, a diagnosis is suspected of endometriosis, PCOS, pelvic adhesions, uterine anomalies, testicular pathology, or impaired sexual intercourse, that couple should start treatment from the beginning. They do not need to wait for 6 months or 12 months before they are managed and evaluated by a reproductive medicine specialist. But who's to blame for infertility causes? So here we can see that male factor is really important in the infertility causes. It's about 35% of the causes of couples with infertility. Besides, tubal factor is also 35% of the causes, ovulatory dysfunction 15%, other causes like uterine pathology 5%, and 10% of the couples are going to have unexplained infertility where everything apparently is okay, but they can't get pregnant. And this is really important. 30% of the couples are going to have combined diagnosis where there is alterations or pathology in the male factor and also in the female factor. So as you can see, infertility is a couples thing. It needs to be studied and needs to be managed as a couple. And how intense must we be in the infertility diagnostic workup? So this is a concept of ASRM, the American Society for Reproductive Medicine, in concordance with ACOG. And they say that evaluation of infertility should be conducted in a systematic, expeditious, and cost-effective manner so as to identify all relevant factors with initial emphasis on the least invasive methods for detection of the most common causes of infertility. The couple must be studied concurrently, and the patient extent of evaluation should take into account the couple's preferences, patient's age, the duration of infertility, and unique features of the medical history and physical examination. And what are the main points in infertility workup? So, as many things in life, male analysis infertility is a little bit simpler, easier, and shorter. Usually, male with a semen analysis, we kind of have a general idea and good evaluation of its reproductive potential. In female, it's a little bit harder. We need to put into consideration many more variables and many more issues that we have to evaluate. And this is mainly the 4 points that we want to have and consider in infertile couples. First, the ovulatory function. Second, the tubal function. The third, the uterine cavity. Fourth, the semen analysis. And I would include a fifth variable, and is to study and have into consideration the possibility of endometriosis that each time has a higher influence in the options and the workup of the infertile couples. So how to study the ovulatory function in women? So in this slide, we see a little bit of a summary of how to analyze that ovulatory function. First, we want to know if that patient is ovulating spontaneously or not. Classically, we've done that with endometrial biopsy to see if the endometrium has a secretory phase of that endometrium. But definitely today, the best tool to analyze that spontaneous ovulation is the progesterone measured during the mid-luteal phase, 7 days before the expected menstrual period. So around day 21 or 22 of the cycle. If that blood level of progesterone is over 3 nanograms per deciliter, the possibility of that woman having ovulated spontaneously in that menstrual cycle is over 95%. So progesterone is really useful and an easy test to measure that ovulatory function of the patient. Of course, we can also use LH ovulation kits that detect the LH peak before ovulation. And we can also use the ultrasound to do the follicular follow-up and to see when the follicular rupture occurs. And that way we can also evaluate spontaneous ovulation. But we also want to know not only if that patient is ovulating spontaneously, but also what is the ovarian reserve of that patient. If we have a good number of eggs or not in that woman, to be able to do a prognostic assessment of her options in infertility treatment. So we classically have done that, measuring basal FSH on day 2, 3, or 4 of the cycle with estradiol. But not anymore. There's better tools now. We have the anti-Mullerian hormone. That's a hormone produced by antral and preantral follicles, and that is a really objective measurement of ovarian reserve. And of course, the antral follicle count, that is the counting the follicles between 2 and 10 millimeters on day 2 or 3 of the cycle through a transvaginal ultrasound. That is really good also in the assessment of the ovarian reserve. We also want to know other aspects that can influence ovulatory function in that woman, thyroid function and levels of prolactin. And of course, if we suspect PCOS, that's a different area. But of course, we want to know also the levels of testosterone, free testosterone, DHEAS, 17-hydroxyprogesterone, and possible basal insulin levels and OGTT. When we used the FSH and estradiol for ovarian reserve analysis, we wanted to have an FSH under 10 and an estradiol under 80 to see or to diagnose a good ovarian reserve. We also used clomiphene citrate challenge test when we measured FSH before and after administration of clomiphene, and the sum of those two levels should be under 26. But those tests are basically not used anymore because, as I said before, we have better options. We want to have an anti-Mullerian hormone over 1.06 to say that we have a good ovarian reserve, and we would want to have also a natural follicle count over 5 or 7 to diagnose a good ovarian reserve. This was published in 2010, and the comparison of these methods to detect ovarian reserve or to determine ovarian reserve is done. They compared age, mean ovarian volume, basal FSH, basal AMH, and total antral follicle count. And as you can see, the area under the curve for total antral follicle count and basal AMH had a better sensitivity and specificity than the other variables, but were very similar between each other. So today we can say that antral follicle count and AMH are the most significant predictors of ovarian reserve and, of course, of poor response to ovarian stimulation during assisted reproductive technologies. How to study fallopian tube function. So we have different tools. We have hysterosalpingography, we have hysterocontrast sonography, and we have laparoscopy. Hysterosalpingography is the most used method to evaluate tubal function. It's got pros and cons. In the pros, we find that we not only can evaluate tubal function, but we can also have not exact and not very good, but moderate evaluation of the uterine cavity in one test. It's a low-cost test, and it's less invasive than other tests like laparoscopy. But in its cons, it's a screening method. It doesn't give us a definite diagnosis. Usually when we have an abnormal finding in hysterosalpingography, we need to go to a laparoscopy or to a hysteroscopy. So it's a screening method. It cannot give us the option of diagnosing endometriosis in that patient. It has a low therapeutic effect. It's been described to be associated with a 2% of spontaneous pregnancy after HSG. It's not a high possibility. It's low. It does have a therapeutic effect, but it's low. And it's a painful treatment. It's a painful test. It's not done under anesthesia. So patients really, really report high intense pain during the procedure. Laparoscopy is kind of a gold standard for tubal factor evaluation. It's got several pros. It's a definite diagnosis. We can see not only if the tubes or the fallopian tubes are patent or not, we can also see if there are motile, if there's adhesions that are affecting the possibility of that tube capturing the egg released by the ovary. We can see the fembral component of the fallopian tube. We can also diagnose and treat endometriosis in case we find it. And it gives us therapeutic options like treating endometriosis, like treating pelvic adhesions, like opening obstructed fallopian tubes, etc. And its cons, of course, it's the cost. It's a surgery of higher cost, and it's a more invasive procedure. It's done under general anesthesia, and of course, higher complication rates than other simpler tests like HSG. So laparoscopy is indicated when we suspect endometriosis in that patient, when we have any history or findings in the ultrasound or the physical examination that makes us suspect pelvic adhesions or tubal disease, or when those patients have positive chlamydia antibodies. Hysterosalpingo contrast sonography is another option. It helps in the sense that it's a good evaluation of the endometrial cavity at the same time where you are evaluating tubal patency. But it has a big con. The tubal function evaluation with HICO-C is highly operator dependent. Okay, so we need a good quality operator to be able to have good sensitivity and specificity with this diagnostic test. In good hands, it has been compared with HSG and laparoscopy, and both tests have had high diagnostic accuracy compared to laparoscopy, with a sensitivity of 0.92%, 92, and specificity of 0.95, and a negative predictive value near 100%, but with good operators, okay? This is another aspect that we can use, the chlamydia antibodies. The chlamydia antibodies have been used compared to laparoscopy to determine the presence of tubal pathology with a sensitivity of 40 to 50%, positive predictive value of 50, 60%, and a negative predictive value really high between 80 and 90%. So, how do you use chlamydia antibodies to assess tubal function? You have two possibilities. When that woman has no risk factor for tubal disease in her medical history, you can do chlamydia antibodies. And if the chlamydia antibodies are negative, that patient probably does not require further tubal assessment because less than 50% of those patients are going to have tubal pathology. In case the test is positive, further tubal evaluation must be considered, like HSG, laparoscopy, or HICO-C. The other possibility is that that woman does have high risk of tubal disease according to her medical history. In those cases, you will not use chlamydia antibodies. You will probably go directly to do HSG, laparoscopy, or HICO-C. Remember, HICO-C if you have good quality operators because it's really technical dependent. How do you do uterine cavity evaluation in an infertile woman? So the gold standard is definitely hysteroscopy. We used to do uterine cavity evaluation with HSG, but we now today know that many times small masses like endometrial polyps or endometrial fibroids under 8 millimeters are not going to be diagnosed and detected with hysterosalpingography. We do have a better evaluation with a hysteroscopy that is definitely the gold standard for uterine cavity evaluation. But we also have other options. HICO-C is really good in uterine cavity evaluation. It not only allows you to evaluate the uterine cavity, also the tubal function. It's low cost and it's less invasive. But also 3D ultrasound is a great method to detect Mullerian anomalies, and it's definitely very less invasive compared to the other methods. You can also use combination of methods. You can use HICO-C with 3D ultrasound and have a pretty good evaluation of the uterine cavity. HICO-C for uterine cavity evaluation has shown high sensitivity and high specificity compared to hysteroscopy when you see this area under the curve. And definitely it's a much better analysis of the uterine cavity compared to HSG. When you see HSG with a sensitivity of 37% for uterine cavity evaluation versus 80% for HICO-C. In male factor evaluation, we obviously have the semen analysis. The semen sample must be obtained through masturbation with 2 to 7 days of sexual abstinence. It should be analyzed within 1 hour of having taken that semen sample. and it's got a good negative predicted value. A normal semen analysis excludes male factor 90% of the times. And these are the normal ranges for semen analysis published by WHO in July 2021. We should have a volume between 1.5 and 5 millimeters per sample. Sperm concentration should be over 15 millimeters per ml. Motility should be more than 32% of progressive motility, either slow or fast progressive motility. Morphology should 4 or more% of sperm cells should have normal morphology, and vitality should be over 58%. If you have an abnormal semen analysis, you should repeat a new semen analysis at least with 30 days of difference with that first semen analysis. A diagnosis of a semen abnormality should not be done with just one semen analysis, because we men have a big variability in our semen parameters due to different conditions: viral infections, fever episodes, use of several substances, stress periods, etc., etc. Besides, those males with an abnormal semen analysis should have a physical examination to see testicular size, to exclude the diagnosis of varicocele, and laboratory tests, hormonal tests like testosterone, FSH, and LH, and the possibility of doing a karyogram. Also, an analysis by urology to detect possible abnormalities. Here we see how we can assess that male factor with an abnormal semen analysis. If we find oligozoospermia, diminished number of sperm cells, teratozoospermia, diminished percentage of sperm cells with normal morphology, astenozoospermia, diminished motility, and necrozoospermia, diminished vitality, then we should go to laboratory evaluation and urologic evaluation. If we find a low testosterone, a high LH, and high FSH, then we can diagnose a primary testicular failure and we should do a karyogram. If testosterone is normal, but we have a high FSH, so we can diagnose a germinal compartment failure, we should test for Y chromosome microdeletions and refer to a specialist and probably for ART. If we have low testosterone and low LH and FSH levels, we diagnose a hypogonadotropic hypogonadism, and that patient could be managed with hormonal supplementation of FSH, LH, and HCG. And if we have normal testosterone and LH and FSH levels, we should exclude in that male anti-sperm antibodies. We should rule out obstruction, and we can also do analysis for Y chromosome microdeletions. Once we finish this, we should not leave out the analysis of a possible endometriosis. Today, we know that severe endometriosis is associated with infertility because of adhesion formation, because of tubal obstruction, and because of diminished ovarian reserve in patients with severe endometriosis. But also, mild endometriosis is related to infertility because of the production of interleukin 1, interleukin 6, TNF, and some prostaglandins that go to the peritoneal fluid and cause a hostile biochemical pelvic environment with affection of folliculogenesis, sperm transportation, early embryo development, and implantation. So we definitely should look for endometriosis. Today we know that patients with endometriosis have a threefold increase in the possibility of infertility. 45% of those patients with endometriosis will have or suffer infertility. We also know that the fertility potential is definitely diminished. The normal possibility conception per menstrual cycle of 15 to 20% is diminished to 2 to 10% in patients with endometriosis. And we also know that in infertile women, the possibility of finding endometriosis in a laparoscopy has been reported between 30 and 50%. So there's a close relationship between endometriosis and infertility. Finally, if you have studied this couple and you have a normal semen analysis, paid-in tubes, normal uterine cavity, and normal ovulatory function, you have a non-explained infertility that occurs in approximately 10% of the couples. In those couples, the most important issues to go into and look and do the diagnosis is probably going to be endometriosis and pelvic adhesions. But you can also look for other pathologies that don't have that much evidence, as luteal phase deficiency, sperm function tests, anti-sperm antibodies, genetic analysis, and postcoital test. Conclusions. First, infertility diagnostic workup should be done on couples with at least 1 year of periodical unprotected sexual intercourse without reaching pregnancy. This period should be 6 months if the woman is 35 years or older. It should be done, that diagnostic workup should be done right away in couples with conditions associated with infertility, such as endometriosis, PCOS, PID, or testicular anomalies. Diagnostic workup should include both members of the couple and must be completed expeditiously. Most couples with infertility have a diminished but not abolished possibility of a spontaneous pregnancy. The best name for this diagnosis should be subfertility. Infertility diagnostic workup must include semen analysis, ovulatory function analysis, fallopian tube function analysis, and uterine cavity evaluation. And never lose endometriosis from your mind and from your diagnostic workup. Finally, when you approach this couple, you can include these tests for your diagnostic workup: the semen analysis, luteal phase progesterone, AMH, transvaginal ultrasound with antral follicle count, HSG or HICO-C or laparoscopy, hysteroscopy, or chlamydia antibodies, FSH, TSH, T4, and prolactin. That's a little bit of a summary of what we just went over. Thank you very much. This is our group. Thanks for being with us here, and I hope that this last few minutes can contribute to the practical analysis of the infertile couples that you manage on a daily basis. Thanks a lot.